So I am excited to have this panel with us today. I think we're going to hear some really exciting things and have lots to talk about at the end. We will be holding our questions till the end, so if you have a pressing question for one of the earlier panelists, please jot it down on your notepad so you don't lose sight of that, because we want to make sure everybody gets their questions answered. Oh, here we go. Okay. So this panel is on increasing access and opportunities for quality health care. Leslie Porth's going to lead us off. Leslie's the vice president of the Missouri Hospital Association, and she has a new title that she's going to tell you all about that I find very exciting. I'm very happy for her. It's going to be good for Missouri citizens. And then Louise Probst is going to talk about transparency in controlling costs and improving care. Louise has worked for transparency in this state for a very long time, and I would say she's our transparency leader in Missouri, so we're excited to hear from her about that. And then lastly, Jeremy Malarski is going to be here to talk about the navigators in the new health insurance marketplaces, and he's one of our more experienced Missourians in this area, and I think you're going to learn a lot of interesting things from Jeremy. So without further ado, I'll ask Leslie to lead us off.
What an incredible day, and thank you, Dr. Edison, for the invitation to speak and for your leadership and your vision. This has been an incredible day so far. As Karen said, my name is Leslie Porth. I am the Division Vice President for Strategic Quality Initiatives. I'll talk about that in just a moment. And I oversee many and most of the clinical activities and improvement and areas for the Hospital Association. One of those of which is emergency preparedness. So I will tell you it is nice to have a day and a short reprieve from Ebola, because somebody said something to me yesterday on a call, and they said, I can't wait for this to be over, and I said, grab a Snickers, you know? So before we get into this, I have a disclaimer about myself, and that is I am an optimist. I am an eternal optimist. I didn't lose it in my youth. I'm in my middle age, and I still am an eternal optimist. And I know these are really challenging times, but I see incredible opportunity. So understand that's my bias going into this, and I drive my staff crazy, but I'm always thinking, all right, I know this is a little bit tricky, but how can we keep moving? So today I'm going to talk to you about the Triple Aim journey. And what you know and what you've heard today is these are really, really challenging times. And I'm not going to belabor this point. We are in an era of punctuated change. It is truly transformational. It is truly revolutionary. The external forces that are on our healthcare system, the political, the economic, the financial, the regulatory, are daunting. And so that creates incredible challenges thinking about how to deliver care. And what I will tell you as a person that represents and helps and supports the hospitals and healthcare systems across the state is the internal environment is equally stressful. And most of you that are working in or around those organizations know that. What I see when I go into the hospitals today is there is incredible mission fatigue. They are worn out, because every day there are new challenges, new constraints, new cuts, staffing changes, staffing decreases, and requirements to continue to do more. I just recently, and I'll talk about this in a second, inherited all of our quality activities. And in some of my interviews with hospitals, they're saying, every week there is somebody asking us to do a new quality initiative. We are collecting so much data, we don't even know what we're collecting, who we're giving it to, and we never get it back. So how are we setting the stage for improvement with that kind of environment? So we have to think strategically about how we offer better health, we offer better care, we create more value, and we lower cost. It is the triple aim that many of you are familiar with. The reality in a nutshell is the old model was volume-based, it was fee-for-service, and the more heads in beds, the bigger the reimbursement. The reality is today, the incentives are very, very different. It's value-based, it's outcomes-based. You are expected to give excellent care. You are expected to manage the population and the health of the community that you serve. And so the challenge for the hospitals and for the broader healthcare systems, there is less money coming in. We've heard about it today from Ezekiel and others, especially with the inability to pass Medicaid expansion. There is an expectation for increased quality, and those are our challenges. On top of that, you look at our health status. I am sitting here with friends and colleagues around the state. You know this. I don't have to belabor this point. But when you look at objective measures such as life expectancy, and you look at objective financial measures such as health expenditures, and you see that the United States is the only one in the high-cost, short-life quadrant, and Missouri, in fact, has a little bit less life expectancy than the country average, you realize we're doing something wrong. Something has to change. One of the things that has happened, and as much as I wish it weren't true, I agree with Ezekiel this morning when he said information and knowledge don't drive changes in behavior and changes in the system. My graduate degree is in public health. I wish that were true, but it's not. And I think with the Affordable Care Act, we saw that as well. And so what you see in the evolution of financing for hospitals is the expectation for outcomes to be paid or penalized based on how you do. And right now, as of October 1st this year, the care we are delivering today in our healthcare systems across the country is driving the formula that will dictate the payment reimbursement in federal fiscal year 2017. So this chart in front of us is what hospitals should be doing today with accuracy, because everything that they're doing today cannot affect payment until 2017, but it absolutely will. And for those of you, I won't get into a lot of detail here, but for those of you that are familiar with the old Hospital Compare Core Measure program, that drove much up to 70% of the reimbursement formula. Now it is only 5%. So the expectation is we don't care about counting activities and widgets anymore. We expect and are measuring outcomes. I think personally that is an important and fundamental shift. And I will tell you, I think it's been harder to implement than maybe many expected. So you see the percentages of finances that are driving based on clinical care outcomes, the experience of care, safety, and efficiency. So at the association, as Karen alluded to, we have a new approach, a new strategy, and we are following the trend of many national strategies. We are not sitting there in isolation in our offices in Jeff City coming up with random ideas. There are many reputable national groups out there that are really thinking innovatively about how we deliver care differently. You've heard some of that today. And these are some of the groups that we are watching. But we have great leaders in our state, and so we're thinking, how do we work with the Center for Health Policy and our other stakeholders, and how do we do this innovatively and creatively? Some of you may be familiar with what was termed the Hospital Engagement Network. And it was funded through the Affordable Care Act. It was a 2-year pilot, and then it received a 1-year funding extension. The program does expire December 8th of this year. It will not be continued in its current form. It's a CMS pilot initiative, and it was funding across the country to help hospitals shift from that process measure, counting the activities, to measuring outcomes. And again, it was a fundamental shift. MHA, as part of a network under the American Hospital Association, participated in this program. We had in our particular HEN, we call it, 96 hospitals that participated in ours, and in total in Missouri, I believe we had 112 of our hospitals participating in this national pilot. So big footprint there. And it was a revolutionary change to think about quality differently in hospitals, and it was using cross-cutting strategies and I won't read them to you there, but it was engaging key partners. It was changing the culture of healthcare delivery. It was addressing disparities, and it was using data to drive the analysis and the management. And the expectation was that we reduce harm, that we reduce infections, and that we reduce readmissions. And so the national goal was to reduce by 40% obstetrical harm, adverse events, and infections, and reduce by 20% readmissions. So we have that going on, and we also think about our current model. Hospitals and healthcare systems are very accustomed to utilization, and it's how many people are coming through the ED, how many people are admitted, how many procedures are being given, how many surgeries, et cetera. And so we've looked at hospital utilization in the traditional model, and that was really driven by the clinicians and your finance and data folks. But on the other side of the hospital, another wing of the administration, perhaps, was your marketing division. And that's where they were talking about, and your health planners and some of your payer groups. And that's where they were talking about community health. And they were talking about it from a marketing perspective and in a market share perspective. And along with the HIN and along with all of these changes in the Affordable Care Act came the requirement for not-for-profit 501c3 hospitals. They must do a community health needs assessment. And they must do that in order to help maintain their 501c3 tax-exempt status. And I will be really honest with you, this first time out, most of them were filed and conducted in 2012. They're getting ready, it's a 3-year cycle, they're getting ready to cycle back in 2015. To be honest with you, the first time out of the gate, in large part, the hospitals were a little bit overwhelmed by it. It was a new process for them, a new activity for many of them. And it was really just kind of completing the exercise of the assessment. We are really working with them to help them think, you've got this incredible resource of data and information about your community and your population. You need to think about how you can tie that together with the utilization patterns and determine what those common goals are in your organization and how you can begin to draw a line from within the 4 walls of the hospital, outside those doors, into your community, into your post-acute settings, into your primary care, and engaging your other community partners. And so that's what we're challenging them to do. Traditionally, what hospitals and healthcare systems have done, they have donated, they've been aware of and advocated for social issues, they've sponsored heart walks, all sorts of activities such as that. In these early stages of healthcare reform, we're thinking about aligning. You'll hear, and perhaps you've heard today about hotspotting, finding those geo-specific zip codes, and we're diving in there with community health workers or nurse practitioners or all sorts of innovative models, and that's very important. But I'm going to challenge all of us in this room, as I do my committee and staff and members and everyone else, and that is we have to innovate. We have to think about how we partner differently, we gain new subject matter expertise, we facilitate, we innovate, we implement, and we evaluate. There is incredible opportunity here. So we at the association have a new division. It is the Strategic Quality Initiatives Division. That is what I lead. We have made it our mission, and our board has approved that we will adopt and implement the AAA framework. We are implementing strategies to coordinate care across the continuum, that we are integrating prevention, population health, and preparedness, emergency preparedness. Think about, this Ebola thing is just a great opportunity. Think about resilient communities, informed communities, and think about how that transitions into the broader domain of what we are doing in population health. It's engaging new partnerships, and it's utilizing science to drive our decision-making and to guide and evaluate our improvement efforts. So we have a whole host of new stakeholders today, and it's been funny. I've shown this slide 4 or 5 times, and it may happen to me today. I'm running out of space. Invariably, I will present it and I will talk about it, and somebody will come up to me afterwards and say, ooh, you left off so-and-so, and they're right. So I keep adding and adding, so I'm going to have to reduce my font pretty soon, or my little circle or something. But I think it speaks to the depth and the breadth and the richness of the partnerships and the opportunity here to think differently about how we give care. So we have a new advisory committee, and I think I saw Dr. Mandel pop in. I don't know if he's here. Maybe he just stepped out. Dr. Keith Mandel was in here for a moment. He was like, it's Leslie, I know her. He walked out. He's on my committee. So I was going to give him a quick shout out. But that committee is helping us drive the transition from that HIN program that helped us really identify a new way of delivering quality resources and care in the hospitals to a self-directed MHA-driven strategy that we are driving within this state, and really to provide us that subject matter expertise. And our principles, by the way, we are adopting the triple aim. We are using any initiatives developed by this committee. They have made a commitment that they cannot be used for competition or marketing, and because some of them require board approval, which will happen hopefully next month. I'm not going to elaborate on those, but this group is very proactive and progressive, and they're thinking innovatively, and I'm really excited about that. And we also want to incorporate a sense of urgency. This is time critical right now. Synergy, we need those partnerships. Bravery, it requires risk to get out there and innovate. We know that. And a little bit of thievery and shared learning. So this is our committee composition. I won't belabor you with it. We have all hospitals by size and geography represented. We want to continue to build it out. Once we get this established, we want to bring in external stakeholders into this community. We're not quite ready yet. We have 3 board members that serve on it now and 3 board members that will serve on it after January of 2015. We are bringing in highly credentialed clinical experts to help us drive this. So our goals and our objectives are to increase organizational efficiency and effectiveness, really identify and share best practices, demonstrate outcomes, and share that story of improvement. We really, what is the phrase, all boats rise, raise the tide, whatever that is, that we're trying to raise the bar and the standard of care in every hospital and healthcare system in this state. So we have focused on 3 to 5 priority areas. We are thinking about this from the context of decreasing variation. That's what we want to do. We want to decrease variation. We want to introduce population health. And I will say to you that in many hospitals, they are clinical experts that have come up through, and their education and their practice have come from a framework and a lens of providing excellent care to an individual. They see an N of 1. So when we talk about population health and we talk about an N of 100, that is a big learning shift for a lot of our facilities to think about this from that context. And so that's what we are doing. We have identified measures. I won't belabor this with you, but we have identified 17 measures, 17 topics, 19 measures that we are going to begin putting out in state aggregate dashboards in January. We are working on them now, putting those together, and we'll be segmenting that in some breakout characteristic. We're still working on that, whether it's bed size or some other parameter. But we are committed to sharing those data initially as statewide aggregate level. Long term, we've had discussions about transparency. So our strategy, and this is our focus, we're going to focus in 2 areas. The first area is care coordination. This is the area where we most critically need other external partners. This is the continuum. This is population health. And the areas that we are focusing on are managing chronic disease and reducing readmission. And you will see there the specific clinical diseases and conditions that we are talking about. Our other domain that we are focused on is clinical excellence, and it's reducing infection and reducing harm. And you're looking at, again, those very specific clinical areas. And I had this kind of aha about 4 o'clock this morning when I was working on Ebola. And and my staff doesn't know this yet. They're not going to be happy. But what occurred to me was, on the emergency side of my brain and the Ebola side of my brain, we're talking about how we've got to help hospitals and use decon and hazmat experts to train on donning and doffing the PPE, so that because they know how to do it really well. And what I'm hearing in national calls across the country is nurses are not as expert in that area. They don't do it as well. And I had this aha. Well, that's why we can't get our infection rates down. So, okay, see, I am an optimist. Maybe the lemonade here in this Ebola situation is maybe we change the way we're training nurses on donning and doffing and precautions and PPE under this experience of Ebola, and using that kind of decon hazmat mindset. And you know what? Concurrently, I bet we reduce those infections. So I'm really excited to get back to my staff at 4 o'clock and tell them that. And I know they're going to be really excited too. And falls, all those things are so critically important. My daughter is a psych tech in one of the hospitals in the state, and she had a gero patient fall the other night. And I said, Mackenzie. She said, Mom, it can't be helped. I said, oh, yes, it can. So we're working on that. So it's about collaboration. And I have been in this field of collaboration for a long time. I've done some things well. I've done a lot of things not so well. And what I've learned are a couple things. It is okay, and I didn't believe this a few years ago, it is okay to come to the table with different agendas. It doesn't matter why you're there. If you and different organizations come together with a common goal, that's all you need. I don't care why you're here. I know why I'm here, but we both know we've got to work on this problem, and this is why. And we have to ensure that those with authority for decision-making and resource allocation support the goals and the objectives of the collaboration. Too many times, inspired champions come together and they talk about this kind of nirvana world that they want to live in, and the people with the checkbooks and the decision-making authority are not behind them and may not even be aware of what they're talking about. It's a critical mistake, and it wears down your champions. You've got to find those champions. It takes time to build trust and systems. You cannot have in your first community or collaborative meeting, agenda item after introductions is, agenda item number 2 is, establish trust. It doesn't happen that way. It takes time. And you have to learn sometimes how to trust each other in this space and work collaboratively over here while we're competing over here in this space. And that takes a very established and refined relationship, but it happens, and we're doing it every day. And we have to measure and evaluate. So those are kind of my ahas. They also mirror the conditions for collective impact. And I'm a believer it's a model that has come, I believe, out of Stanford. And so I think about, how can we think about collective impact in this area? And it is a common agenda, shared measurement systems, mutually reinforcing activities. Maybe what Linnell is doing in her program and what Karen is doing in her program are a little bit different than what I'm doing, but we're all working on diabetes, or we're all working on readmissions of CHF, and we're all communicating similar and like messages. You strengthen synergistically the work that's being done collectively within that community, within that population. It's continually learning, continually communicating new approaches, structure, and process, and you've got to have backbone support in organizations. So this is my contact information. It's there. I think it's in the handouts, and I welcome any questions at the end. So thank you.
Well, I want to thank the University of Missouri and Dr. Edison as well for having this program. It's been great today, and I've enjoyed the speakers and appreciate having the opportunity to speak with you. My job today is to give you sort of the perspective of the employer who's offering benefits, the employee benefit manager. Sometimes they're now beginning to think of a population health manager for the corporate workforce, and how they look at transparency. I appreciate Karen's comments about being an advocate for transparency in the state. I can acknowledge that for as long as I've been in the state, which is over 15 years, right about 15 years, the employers have wanted transparency. We've worked really hard on it. We haven't made a lot of success until recently. And I don't know that success is necessarily a part of our hard work, but I think it's a part of what's going on nationally, changes with the ACA and the federal government towards transparency, just the level of cost that's gotten everyone's attention. But we are doing some things differently, so I'd like to share those with you. First slide is just really to tell you who we are if you don't know. And our job is to help employers get more health for the investments that they make in benefits. And our group has 3 strategic objectives: to improve health, achieve transparency, and align the recognition and rewards in healthcare. Our organization was founded in 1982 on something called the Tenets of Buy Right, which was very similar to this, but in 2004, when Crossing the Quality Chasm was published, we took a look at that, and they really gave a job description for every stakeholder in healthcare to say, this is what you all need to do if we're going to put healthcare on a sustainable path. When we looked at what they said purchasers should do, they said we should improve health, achieve transparency, and align the recognition and rewards. And so we adopted those as our objectives, and last year went through a strategic planning process and decided that they still work for us. So I wanted to start by, we were asked to maybe bring a one-page handout, so this is mine. It just so happens that last December, through our strategic plan, our employers, when they came together and they reaffirmed their commitment to transparency, they said, well, we're really not sure that we all mean the same thing when we talk about transparency. So we spent a couple hours together and really asked the employers, and they helped us think about what they mean by transparency. And so they define it as timely access to comparative information on the quality and price of specific services, treatments, and providers, and the financial incentives which might influence decisions about the medicines, treatments, and procedures recommended to patients. And boy, it's that last part that I think is really important and that we hear more and more about. And I was just thinking the other night, I was out socially at a dinner, and a woman turned to me and said, my son has chronic inflammatory bowel disease, and he's been treated pretty effectively for that. He's, not really had too many exacerbations, but his doctor moved, and he's gone to a new doctor, and that doctor's changed his medicine and how he wants him to manage it. Do you think that's because that doctor's making money on those medicines? And I was so surprised, and of course I have no idea. I really don't know. You need to talk to your doctor, but a few months before that, a woman said to me, my sister has a brain tumor, and she's being treated, and her doctor's been having her get, her brain tumor is such that they've told her, no one can really operate on it and give her a reasonable chance of functioning. And so she's chosen not to have surgery or an intervention, but they were watching it every quarter. And her doctor suddenly told her she only needs to get it checked, to see if it's growing every 6 months. And her sister was terribly worried that maybe that had something to do with the financial incentives. That her physician maybe now was with a different health plan or in a different reward system, or the hospital now is on a risk, and is that driving it? And while at some level I think that that's good because the public is aware of things, on the other hand I think that's really, as a nurse, I think it's really sad. I think the connection between the patient and the physician is so important, and if you can't trust your doctor, and part of it goes because I think we've had this transition from medicine as a profession to medicine as a business. And so just yesterday I got a letter sent by a hospital to a patient saying, you might want to go to this freestanding X-ray or radiology center, but you might have to have you might have to have your study repeated because their machines may not be as good as ours. And it just seems like we've got to get the patient. These kinds of things, even though they make sense, they really do diminish that relationship and that trust, which is really kind of frightening. So I just wanted to focus on that a little bit because as Dr. Emanuel pointed out, these are really tough times for everybody, clearly for hospitals. But finding a new way is going to be hard, but let's try to think about that part of the transparency definition. We quickly came to the definition that we meant price. And this is always one of the things when you start talking about transparency, people say, well, which number do you want? Because there are so many numbers in healthcare. And we don't want charges. We don't really care about the negotiated rates or the cost. We don't want to know what a hospital or a physician organization's cost is of providing the service. We want to know the price. The price is our cost. It's our cost of doing business, but it's what we pay for the service. So what we think about that when we talk about price, it's the amount that the patient and the plan together paid for a service. So it's the total cost. And we'd really like to know what did that happen to be for patients with similar services in the same health plan over the past 6 to 12 months. So we want to know an average price. We understand that not everybody's going to use the same inputs and do everything exactly the same way or have the same risk burden or complicating conditions. We want to know an average. And I think that's what our group came to in terms of thinking about what they meant as transparency. Who needs the information? We put patients and families first, but I will tell you that the employers in that room were really clear. They want transparency for physicians. They really, really want physicians to have access to information. They think that doctors need to know and should know on a large basis how the care they provide compares to best practices and the care provided by others. They also want them to know the scorecard, the batting record for those that they refer to, whether it be a treatment, a medication, or a facility or a service. They want them to know the safety profile, the quality profile, and the cost of those services so that they can really make an informed decision when they're referring people for services. Clearly, we want patients and families, and the employers spend a lot of time thinking about this idea of shared decision making, and they understand that some people are going to choose a higher cost or a different path, and they're okay with patients doing that in terms of their own preference for their values, but really wanting to make sure that they do have the total picture. And I think we've seen recently in some national press, the New York Times did an article about parents choosing a lower cost appendectomy when they were really given some different cost comparisons and quality comparisons. So I think there's increasing evidence that when people are fully informed, they don't necessarily just want the higher cost procedure, which traditional wisdom has told us the case. And I think that's obviously because when you don't know how to measure quality, it's kind of like champagne. You think, well, it must be better if it's more expensive. And so as people are sat down and given the information, maybe they'll make higher value decisions. I can't say that's been the track record in the past. Employers want it so that they can think about how to align the rewards. I mean, employers are frequently held accountable for not stepping up to the plate and doing what they should do as purchasers, and that is buy value. But if you don't know value, and everyone is coming to see you and saying, buy our bundle or buy this, or we're the high value provider, and you haven't seen that data before, it's really hard to know where to align those rewards. We are seeing more of that information available, and we're starting to see employers move into more selective and more direct contracts than we have in the past. Clearly, we want hospitals and health systems as well to have that information, and I think for the reasons Leslie mentioned, we're really thrilled to hear about, we're familiar with the HENS networks and the good results in the Partnership for Patients, and we're pleased to hear of a stronger collaboration statewide to do some of those things as well. And then we also think that communities really need to know their score. We as a community maybe need to understand what our rates of the chronic condition are, and we might need to go out to St. Charles and say, do you know that you're pulling the region's average down or up or whatever, or get a little competition going on how healthy our subpopulations can be within a region. But we are eager to start some of our own scorecards on those population health for our region. So everybody needs the information, and I think we'll all be better. When we have trusted sources, it's not somebody's information that just they can see, it's information that we can all share and know. And then we can understand that no one entity is responsible for all the results there, but collectively those are our results. This has come out more and more that it's not just the people that are uninsured that worry about the cost of health care, it's the people that are insured that worry about the cost of health care. Everybody worries about it. There's very few of us that could really afford it. I thought this was really interesting, though, came from the Alterum Institute survey last fall, and they said 9 out of 10 Americans agree that medical care costs too much, no big surprise, but that it costs more than necessary. And that surprised me to think that 90% of the public thinks that it costs more than it needs to cost. And so clearly cost is something that everyone in America worries about. Consumers do have skin in the game, and Dr. Emanuel pointed that out this morning. It's really, really high. So one of the first things I did when I came to my job in St. Louis is a survey. Went out and interviewed all of our members in 1996, I think, about their premium expense and what was their philosophy. And I remember just kind of lining the employers up. There were some that their philosophy was that they're going to pay 90% of the benefit cost. And there were just a couple. There were a few that were only going to pay 50%. I remember thinking, wow, well, those were the retailers. And that was pretty standard in their industry. But most of the employers had a philosophy then that they were going to pay 75 or 80% of the benefit cost. If you go out and look today, those employers that were at the top have moved down to 80 to 75%. Those that are at the bottom have moved up because cost is so expensive. But on average, companies are paying 75% of the benefit, which is the same thing that they paid in 1995. It's just that the benefit is so much more expensive, and it has outpaced wages, so much for the last decade or so, that same, 20 25% or 15% of the health benefit cost that an employee might be shouldering is an awful lot when it's a much bigger portion of their take-home income than it was in the past. Are people familiar with the Cadillac tax? So I know we all know about what's in the ACA as it affects us, and I know you all know how it affects the hospitals and others much better than we do, although we try to watch that. But employers are really worried about this Cadillac tax. It's a 40% excise tax on the cost of health benefits, which is huge. And so at the same time that the ACA is saying you've got to cover all these people and you've got to enrich in your benefits and provide all these mandates, they're saying, but if your cost is over this level, you're going to have to pay this 40% excise tax. That's really frightening. And so what they're doing is going to consumer-driven plans because they're saying, as a benefit manager, I can't get equity for a whole group of people or a population, but I can put people in a consumer-driven health plan and I can let them make the decisions. And so I'm not deciding decisions collectively for their family budget. They're able to do that on their own. And we heard earlier about the dramatic variation. I think you're all pretty familiar with this. But it's something that employers have really just been getting their hands around or thinking about for the last 2 to maybe 3 years. And we're, now that we have our own transparency vendor, we're able to say it absolutely exists in St. Louis. You can find, these kinds of differences and what the message is. So if you're a provider here that's providing a cost in network, these differences are in the same health plan. They are among like-trained providers and like-trained facilities, and sometimes they're even the same provider at 2 different facilities. So we've found that with the colonoscopy. You can go to Dr. Jones here or Dr. Jones here, and you choose, and really, really different price. And so it's not clear that there's a big difference in quality. But what we're saying, as long as we let our health plans do this, we're saying that these low-cost or higher-value providers are subsidizing the high-cost providers. That is wrong. No one's system is going to reward excellence and drive better value if you're letting the low-cost providers subsidize the high-cost providers. So clearly we have a responsibility to do something about it, and we're trying. But it takes a little time. So I just say on this slide, really, looking at this from a national perspective, the veil's been lifted. That's good and bad news, as I mentioned earlier. Hardly a day goes by that I don't get 2 or 3 articles, that I find or that someone sends me that are really interesting with some reporter or somebody someplace that's written about something that's going on in healthcare that, would have felt kind of shocking, but now it's just every single day. I think there's more of it. Robert Wood Johnson, I think 2 years ago, did a survey and put out a directory of 208 national, state, and local public reports on different types of reporting on providers. There's lots of websites that rate physicians. I think that's a little bit, concerning. For so long, we've criticized people for making their choice in the doctor of what their family or neighbor told them, and then we put up websites that ask everyone to do it on those kinds of things. I really hope that we can get some sort of functional assessment type of information out there that would be a lot more useful to consumers. But CMS has done an incredible amount of work. We use their Hospital Compare. We use the HRQ measures and other things in our community to publish those a lot. And just as evidence of how much transparency works, I think everyone in the hospital industry knows how high and how tight those initial Hospital Compare measures were. You can be in the 90-some percent score, like a 94% score, and only be at the 70th percentile nationally. So those really have moved up, and I think that bodes for transparency, but also moving what you're making transparent so that you get more than just a handful of measures with significant quality improvements. But definitely the public sector getting involved in this has really helped. So the employers are saying, okay, my employees are hearing about this. What can I do, and what do I need to do? So one of the things they ask us to do in our planning session is to really invest in communications for the public and for the workforce. So we've been meeting with our health plans communication people and our employers communications people and really working on this. 5 messages we want to communicate. More care is not better. I think that's pretty clear. Higher quality higher cost does not mean higher quality. I think that's really important. In healthcare traditionally, the insurer, the employee, or the patient pays for mistakes. We've seen all the recent reports about how much money a health system makes on infections. And so if my way of thinking that if I go into a community, I don't know anything about it, I better look for a lower cost provider. Because you cannot stay in business and be a low cost provider with a high complication rate. But if I go to a high-cost provider, it could be a big profit margin and or a high complication rate. But if I don't know anything else, I know that a lower-cost provider is not going to have a high complication rate. And so I think that we really need to help people rethink this idea of higher cost means better quality, and I think the information's helping that. I think everyone knows the statistics about too many people being harmed by medical mistakes. We talked about the variation in care, but those are things we need to help consumers understand as well. And then finally, that it's their money. You know, for a long time, probably until about, I don't know, in my mind it was when Schnucks took that big strike. Then the union found out just how much health care really cost. But before that, people thought they were spending somebody else's money. And then they realized, no, the employer's been taking this money out of my back pocket all these years, and that's my money. And it is their money. We all pay. And I always feel bad for the people that are uninsured and for so long were blamed with driving health care cost up because they show up in the emergency room, which we now know isn't really true. But the reality is, even people that don't have insurance, they pay for health care every single day. They pay through lower wages, they pay through higher cost, everything you buy, whether it's gas in your car, the coffee, anything. There's probably more healthcare cost in that than certainly needs to be, but it really is driving down the American standard of living. It's making it hard for people. It's hard for our industries to compete. It's hard for us to keep jobs here, and it's hard to save for retirement, send your kids to school, and do all the things you need to do. And so I think it's all of our job to work on this and to help people understand that they have to be part of the solution. There are a lot of vendors out there I was asked to talk about. So Castlight, Change Health, Compass Health, and Healthcare Blue Book are the ones that we know the best and that we think are really great. Employers are definitely using these. I have one employer that's used them for over 4 years now, and I'll just flip on. We use Compass Health for our own employees, and about 8 of our companies do as well. They take the thing of being a concierge service. So they have a health pro. That health pro, you just send them a note and you tell them what you're interested in. They do the analysis. They call you back. They send you a paper that shows you a map and all the places to go, and they show you quality information and cost information. And then they say, do you want me to call and talk to your doctor's office? Because they say patients don't want to be in the position of having to negotiate with their doctor. So they had that tough conversation to say to the doctor, do you realize this is $500 out of pocket for this person to get their imaging at the hospital versus this imaging center? And if the hospital would bring the price down, they'd be happy to go there, but this is money directly out of that person's pocket. And usually the doctor says, no, I'll be okay with that. And then the patient, they schedule the appointment for the patient. So it takes the patient out of that negotiation. This is Castlight. Castlight has a little different model. Really interesting company. They do, I think, they're more internet-based. And a lot of companies are tagging on. They have a lot of great consumer information. They've invested heavily in that. And so it's more of an internet-based than a concierge-based. And then finally, I just want to say I couldn't agree with Dr. Emanuel enough. Transparency is not enough. Information itself will not change. And employers aren't just using information. There's a lot of different things that they're doing. But consumer-directed health plans are big. I'm sure that we're a little above the national average. I'm sure that more than 20% of our member companies' enrollment are in consumer-driven plans, and that's growing. On-site clinics, more direct contracting, care coordination coaches that really hiring coaches to track what's going on with the patient and connect with the doctor, send the doctor run charts of blood pressures and other kinds of things before the next visit. Bundled centers of excellence, data mining, other sorts of things. So just to convey that it's not the data alone that's going to do it, but it's important for all of us to have that information. Thank you.
Thank you, Louise. That was great. And I just thought, nice little segue. I just learned from Stan Hudson, Associate Director, who is very resourceful, that the person in the purple shirt with the white tie was Ryan Smith, a small business owner from California. So,
good afternoon, everybody. A major theme of today is the Affordable Care Act, and there are many stories behind the Affordable Care Act, but arguably many of these stories are not told in words but in numbers. Many people know that more than 7 million people enrolled in private plans through the health insurance marketplace this past open enrollment period. And here in the Show Me State, where the state motto, Salus Populi Suprema Lex Exo, mentions public health, we had about a little more than 150,000 enrollments. This past open enrollment period, I ran one of the in-person assister programs, a navigator program that was charged with providing unbiased assistance to people in this situation, people who were interested in the marketplace, people who had questions about the ACA, about their eligibility, whether they could get help buying insurance, and what plans were available to them. We served a population that, in many cases, had never had coverage before, it wasn't really on their radar. In many cases, their frame of mind was a difference between life and death. You had people who, didn't think health was important. If I get sick, I'm just going to die. No big deal. So it was profound work. Of those 150 enrollees, 150,000 enrollees, approximately 80% of them received some kind of help buying their insurance. But I don't think that we in-person assisters could take credit for most of those. I would probably be generous to say that maybe 20% of those enrollees were enrolling with an in-person assister there doing the work. And part of the reason for that was because of our mission. We were in charge of serving vulnerable populations, people who weren't as web savvy, people who weren't as likely to be able to go onto healthcare.gov and figure everything out and make an intelligent choice and feel comfortable doing that without some kind of in-person assister or expert with them. Now, it's important not to confuse the in-person assisters with agents and brokers. Although agents and brokers do show people plans and help people buy insurance, we were charged with unbiased assistance. We were required to show people all the options that they had available to them. And we didn't make any money off of it except for the grant money that we received, and I'll get to that in a minute. So there are two main types of in-person assisters that are certified by the federal government. Those are navigators, which I was one, that are funded by the Federal Navigator Grant Program through HHS. And then there are certified application counselors, which can receive funding from either a private source. Some of them are funded through HRSA, through federally qualified health clinics, and some of them receive no funding at all and work within a nonprofit or usually a nonprofit or healthcare organization that can attest to the fact that they can protect people's personal information and be able to provide unbiased assistance. So this is the Kaiser Foundation survey of assister programs, and as you can see, navigators are about 2% of the in-person assister population in the United States. Now, if this were a pie graph of which type of in-person assister got media attention, usually negative media attention, it would look like the flag of Japan. It would be a solid circle with pretty much that was what they talked about was the Navigator program. The main funder was not the federal government, but usually nonprofit and community service organizations. Federally qualified health centers were a big player, and their activity was quite prolific. They had a lot of enrollments. Here in Missouri, there was a similar pattern. The biggest funder of in-person assisters in the state was last year and continues to be the Missouri Foundation for Health. Their coverage area is most of the state, but it's the old Blue Cross zone, so they omit the western part of the state and northwestern part of the state. It can get kind of confusing because they also lead this coalition called the Cover Missouri Coalition, and if any of you were present for Thomas McAuliffe's talk earlier today, he talked about the Cover Missouri Coalition. That's a statewide thing. It's an ad hoc group where we all would network together and share knowledge, which is very, very important. But the funding for their expanding coverage through consumer assistance grants, that's just in that old Blue Cross zone, so the southwest part of the state, middle part of the state, and of course St. Louis. They put $5 million in grants out last year for in-person assisters, CACs. HRSA put in $2.9 million, and the Federal Navigator grants for Missouri were added up to $1.8 million. There were two grantees. One was Primaris, and I managed that program. The other one was the Missouri Association of Area Agencies on Aging. And this is this year. As you can see, it's about the same pattern. The foundation put in the most money. This is a prorated amount, by the way. Their second round of grants is an 18-month grant, but I prorated that so it's only 12 months, so we're comparing apples to apples. But again, you're seeing about the same pattern. About half of it's coming from the foundation, and about an equal amount's coming from Navigator grants and from the HRSA grant program for CACs at federally qualified health clinics. And it's less. So not to complain, but has been a drop in funding for these programs. And again, I will say that I compare it to painting a room. I strongly dislike painting. The bulk of the enrollments are probably straightforward. Nice, simple household. All the children are child dependents. Nobody's divorced. Nobody's newcomer to the country. That's the easy part. That's painting the big part of the house, but painting the cracks, that's a little trickier. That's what the in-person assisters do. We got the hard cases, the complicated cases, the complicated tax holes where the eligibility was not straightforward. Missouri is a federally facilitated marketplace state, in addition to being a non-Medicaid expansion state, in addition to being a state where the state government is prohibited by a proposition in assisting in this work. And these kinds of states with federally facilitated marketplaces tend to have less assisters per uninsured, about half. So if you're in a state where the state is partnering with the federal government to do this, or in a state where the state's doing most of the work and actually setting up its own marketplace, you typically have about twice as many assisters per capita as in a state like ours. Okay, so what does this mean? The first year's over, and we exceeded goals as far as enrollments, but enrollments don't tell the whole story. Most people that we saw came back twice, maybe 3 times. Not because they necessarily had problems, although there were those. Some people had questions about their insurance, had problems with their providers, wanted to know maybe how do I file a complaint? How do I find a doctor? Who do I go to? Do I go to urgent care? Do I go to the emergency room? When do I go to the emergency room? Now, there's been some work in helping the people in those situations. There's a nice coverage to care manual that CMS put out recently to help people understand their insurance, to help people use their insurance, because health insurance coverage is not necessarily the same as access to health care or efficient use of health care. There's a lot of education to be done. But the fact that most of these programs are funded by year-to-year grants is, I would argue, not necessarily conducive to workforce development. This is not easy stuff. This stuff can be very complex, and it requires a diverse range of skills. When we were starting this program, we thought, well, we'll hire people with social work backgrounds. But honestly, many of these skills required marketing skills, people being able to go out in the public and talk about this. I had lunch with a high-ranking HHS official when this first started, and I'll never forget this. The server brought our check, and she put out a health insurance marketplace outreach card. She said, "By the way, do you have health insurance?" To the server. She asked the server whether he had health insurance, and he said, "Well, no, but I'll take your card and I'll tell my friends." That's the kind of successful in-person assistance you need, because there's so little knowledge about this. I mean, this population in this room is probably fairly knowledgeable about the ACA, not so for the general populace. There's still a lot of confusion and a lot of concern about this law. Education is a huge, huge part of it. There are licensing requirements and training requirements. If you are a federal navigator grantee, everyone who you call navigator in your program has to have at least 20 hours of federal training. If you're a CAC, the federal government requires less training, but not if you get funding from the Foundation for Health. They require all 20 hours. And you have to continue to train, because obviously that first stuff that doesn't really get you to real mastery, to really knowing the law, and you learn through failure. You learn through these hard cases. There's also liability costs. So you're dealing with personal information, and there is a lot of, it's extremely important to keep that safe, to keep that secure, to keep that locked up. That takes training. So the future of this program, I'll talk about that in a minute. It's going to require a lot of focus and a lot of knowledge and a lot of spreading of knowledge. So many people waited till the last minute. This graph reflects some of the activity that we saw month by month. As you can see, there were many more counseling sessions than enrollments for each month. That's again because a lot of people just had questions about the ACA. Sometimes they would come to us and they would sit down and find out the prices, and then they would go home and do it on their own. And the Kaiser survey that was done in June, that was done nationally for in-person assisters, about 30% of the respondents said most of their cases they didn't know whether the person enrolled or not. The person would come into the office, talk to them, and then go home, and maybe they enrolled, maybe they didn't. We spent a lot of time with people, particularly during the open enrollment period. The last open enrollment period was a 6-month open enrollment period from October to March. Then it was extended, arguably, for people who had been in line at the end of March. Most people we spent more than an hour with, particularly in the beginning. I remember third day of open enrollment period, we had somebody there for 6 hours. They were very committed to getting their health insurance. They had no English. They had a translator. We had to get a translator for them. Eventually, that average went down, not necessarily because it became easier, but because we had better customer service skills. And if the site was stuck that day, we're talking about October, November, then we would encourage them to come in maybe a day later or the day after, rather than having the whole day blown. We wanted to be respectful of people's time. In addition to helping people in person, we also helped people over the phone and over the internet. And that, again, was because the first question on most people's minds was, how much is this going to cost me? Can I get help buying this? This is very, very expensive. Am I susceptible to the penalty for not having insurance? How much will that be, et cetera, et cetera? So a lot of that was done, we could do over the phone. The actual enrollment had to be done in person. You'll see this spike here in June. That was because some of the rules were clarified after open enrollment period ended and the federal government reopened enrollment for some of those people. The most memorable example is domestic violence victims. One of the wrinkles of the law is it's all about your tax household. And if you're married but you don't file jointly, you aren't eligible for subsidies. So, but think of what that means for a domestic violence victim. Well, if you're fleeing your attacker, you're not going to file taxes with them. So originally, the website did not allow for that. If you were in that situation, you said, no, I'm not filing joint with my spouse, you don't get subsidies. Well, the federal government clarified that in June and said, okay, if you're a domestic violence victim, come back and we'll let you enroll and get a subsidy. So that's why you see that spike in June. We had about 1,800 people come to us in person in our Columbia and Springfield offices, and about 1,600 people, additional people, consult with us by phone or internet, so it's an average of about 150 people. That was probably lower than what you saw in what I call provider environments. Now, keep in mind, this was meant to be, ideally, when the law was first drafted, a partnership between the federal and state governments. In Missouri, it's a partnership between the federal government and a ragtag band of nonprofits and healthcare organizations. So you have in-person assisters who work at community action offices, you have in-person assisters who work in hospitals, you have in-person assisters who work at FQHCs. And you see a lot of variance among how active they were during different parts of the year. And obviously, of course, you have more activity in provider environments. It doesn't take a rocket scientist to figure out why. You're already there. You're sick. You maybe don't have coverage. There's an assister down the hall. Why don't you go, please, sir or madam, go talk to them and see if you can, get help getting health coverage. Well, while you see larger, and this is conjecture on my part, but I think it's an educated conjecture. Obviously, you're going to have higher numbers there in terms of enrollment. But does it speak to the actuarial goal of the ACA? One of the actuarial goals of the ACA is what? Is to get younger, healthier people into the insurance risk pools. If you have older, sicker people, as a majority of people in the risk pools, then this whole thing's going to go in a big death spiral. And the insurance companies it's going to quickly become unaffordable to them. Now, in Missouri, we had almost a third of our enrollees were 18 to 34, so that's good news for the first year. But I would argue that there has to be a diversity among provider and non-provider organizations in order to support that actuarial goal. Okay. So, again, I can't reiterate this enough. The best assisters are the ones who learn the law, know it like the back of their hand, and are militantly positive about outreach and education. Okay. That is probably the biggest value point that we bring to the table, is helping people understand this law, how it affects them, how it affects their family's health, how it affects their family's budget, what are their options. And that can't happen without collaboration, particularly given the fact that, again, there's this mishmash of organizations doing this that are federally certified to do this. So collaboration is extremely important. Networking is extremely important. And for that reason, I think one of the best allies that any sister has in this state is the Cover Missouri Coalition, if I could just give them a quick plug, created by the Missouri Foundation for Health. These last couple slides are borrowed from their year 2 strategy and how they're they're encouraging people to proceed. There's less funding, more grantees, more people doing this, and as a result, that requires focus. So they're focusing on the vulnerable populations in our state, minorities, people living in rural settings, people not necessarily with easy access to health care. And it requires a good amount of action. It's just like in sales. Sometimes it takes 2 or 3 touches, what salespeople call touches, in order to get people to the point where they're ready to make a decision whether to enroll, what kind of options are available to them. And that's what I think is the future of the University Sister program. Thank you very much for your time.
Thank you, Jeremy. I'll also add that the Missouri Foundation for Health has also funded Health Literacy Missouri around the issue of health insurance literacy, because folks who've never had health insurance before, you can imagine how confusing premiums and deductibles and total out-of-pocket costs, and there is a whole other range of things you need to know to be able to use your health insurance. So Health Literacy Missouri has funding to do health insurance literacy in the state. If you have those needs and have populations, you might want to know that. So we do have a few minutes for questions. I think we had 3 great panels, they're all very informative and exciting in their own right. Did you mention how many Missourians signed up for health insurance? I don't remember hearing that.
152,000.
Yeah. So 152,000. And so on my do list, is still to call Robert Pear, who's a columnist for the New York Times. So he came through and they wrote several articles, as you might recall, comparing Missouri and Colorado as desperate states, Colorado expanding Medicaid and having the state helping and having all these billboards and all this, and Missouri doing nothing and being backwards and all this. And I just would like to know if Robert Pear knows that 152,000 Missourians signed up for health insurance. And I think we owe a big debt of gratitude to the Missouri Foundation for Health and for all the Cover Missouri and everyone in the state that went above and beyond to make that happen. Can we just give Missouri a round of applause? Okay, questions for the panel. Linnell.
I thought all of you had a great talk, and I'd love to have a frosty beverage with every single one of you. It was a really nice panel. I do have a question for Professor Fort. So I think I have 2 partners to add to your partnership slide.
Okay.
So you'll have to
I left my notes up there, so I'm going to write on my hand. Yeah.
Okay. To back up a little bit, a couple weeks ago we had our state public health meeting in the state.
Uh-huh.
And I was talking to some of the local health departments about this whole issue of, readmissions and what is local health doing, and are you partnering with hospitals? And so they're telling me that they show up to hospital meetings regarding this issue uninvited, but they put on their best Walmart clothes and show up anyway. And they're telling hospitals, hey, we have a staff of nurses out here. We do home visits. This is right in our mission. We're so happy to go out and take blood pressures and weigh your CHF patients and make sure your pneumonia patients taking your antibiotics and doing the breathing exercises and get your COPD or quit smoking, all that stuff. We're very happy to do that. We'll do it for a bargain basement, fee. We'll save you money, and they're not getting anywhere with this. And so I'm just wondering, what's going on here with the hospitals? Are they just not ready for us, or are they getting
Did you guys hear that question in the back of the room? Okay.
I'll go ahead and repeat it. The basic question was that we have ready and engaged local public health nurses that are wanting to partner with hospitals, and there has been some reluctance or reticence from the hospitals in accepting them as partners. And I would say, her question was, are hospitals not ready for this? And I would say, and I alluded to it briefly, when I was talking about that N of 1 to N of 100, the transition and looking at a population health framework as opposed to providing singular care to a single individual is a much more significant learning curve for our hospitals as a general statement than I anticipated. As I indicated, and as Linnell referenced, I am an advocate and passionate about public health. And so it absolutely is. And we have local public health represented in organizationally, but perhaps not individuals. So you're right, bringing an individual local public health agency director in to help us think through that. But very definitely, you're a huge stakeholder, you're a huge partner. My answer to that is that there still is a steep learning curve here, and it is becoming comfortable with the idea of giving responsibility and sharing responsibility to other entities. And as one of my last slides was, on collective impact, and it is that sharing and that trust development. I think there is probably some work that needs to be done in developing and establishing trust to ensure that it's done and done the way that, nurses want it done, and then building from there. So definitely an opportunity.
The second, to add to your partnership, are academic institutions, specifically students, who are our future. And so, always an opportunity to infuse some student
I like
learning
that.
in this.
I like it. We have academics up there. I don't have students. Yes, thanks.
Other questions back of the room?
I'm a student at Mizzou, MPH and MHA, so...
Do you want to be on my circle?
No. My question goes out to all three of you because you probably have different opinions. It's about how do you define affordability in healthcare? What makes something affordable? Because, if you look at it, most of the research we've been doing in class, some of my colleagues are here, they try to compare the healthcare system with the aviation industry. I mean, it makes sense when you're doing the comparison. They try to compare in terms of quality, but we know that in the aviation industry, when the pilot is going to fly the plane, they're coming from a hotel room or something, in a very nice hotel room. They're walking in, and you have all these engineers, they've done all the checks on the plane, and they say, you're ready to go, you should fly. But in the healthcare industry, it's different. You have doctors jumping from one shift to the other. But if you look at the other analogies I have, in terms of, let's say, fashion industry. If I want to buy something, and I'm going to the mall, I can walk into any store, depending on how much I have, and I can buy what I can afford at that moment. But the healthcare industry is different. Because first of all, you need to get insurance. When you have the insurance, some of these companies are going to tell you where you can go and where you cannot go. That's one part of it. Now, even when you have assets and you're going in, they're still going to tell you how much you can pay to get that service, even when you have insurance, in terms of copay. And for some services, copay could be very high, and copay could be very low. So when you're looking at all this context, when is healthcare really affordable? In the sense that even when I don't have health insurance and I'm making it that self-decision that I want to buy healthcare services without insurance because I think I can afford it. When do you have that thin line between affordability and cost? Because I think it's part of what some of the issues we have. Even when there's assets, for example, someone like me, if I want to I call my hospital when I ask, okay, I want to do something like this, even not necessarily because I have it, maybe just a regular screening, and they tell me, okay, what kind of insurance do you have? Oh, you have to pay this a lot. Don't worry about it, I'm fine. I'll come some other time. And you go into the community, you find there's some other organizations that are actually doing some of these things for free. Maybe it could be a community outreach program. So how do you define affordability? And I would like to have more than one opinion on that.
I'll give a super quick answer. I think that I'm not going to put a dollar price on that, but I think it's an excellent question. I think that the transition in the healthcare industry from process measures to outcomes and transparent outcome results ties then, and it goes to Louise's point that higher is not always better care. And so outcome measures that demonstrate efficiency, effectiveness, and value, to me, are the parameters for affordability. Now, you factor into that socioeconomic status and copays and all of those other variables in there. And again, it's a complicated formula. But to me, the parameters are efficiency, effectiveness, good outcomes creating value.
I have to apologize. I have a hearing deficit, so I couldn't hear everything that you were saying, but I think your question was, how do people figure out what it's going to cost them, particularly if they don't have a lot of extra money and a lot of resource? And I wish I had a better answer for that. I don't. I know in our community, the Missouri Foundation for Health helps fund something called a 411 number where people can call and kind of get guidance on some of those things. But I think that's a really serious issue, and I've even heard when people go to the federally qualified clinics, sometimes you have to, sign up and then come back later. They have to go through a lot of things to test and make sure you qualify, which, I heard about a young man who had a toothache and ended up with then subacute bacterial endocarditis in the hospital, had a big surgery at 50-some years old and ended up dying, which could have been really fixed, but he didn't quite know how to get the right kind of care and obviously suffered for a long time before he finally accessed it.
Well, one of the reasons that I ask you to come and talk about transparency is I believe the transparency agenda and really consumerism in healthcare is going to drive a lot of this change. I talked earlier, you may not have been here, but we had a panel on health information technology, and I talked about direct-to-consumer healthcare. Some of the appeal of that for patients is I know exactly what it is I'm going to have to pay. Or a quick clinic. I sat years ago on a council of, I shouldn't probably say who it was, but on a high-level council of older physicians in leadership in the state at their legislative roundup that year. It was several years ago, and there was a medical student sitting there, and they were complaining about, the quick clinics, in urgent, or like just the quick clinics. It wasn't even retail care then. It wasn't online care. It was just the clinics that people can just go into, urgent care almost, the quick clinics. And they all talked about it and complained, and then the medical student raised her hand and she said, well, I understand all that, but I tell you, I know if I'm sick, I can go there and it's going to cost me $60, and that's all it's going to cost me, and I know what I'm going to get, and I'm going to go there every time. And it just shut them all up. And I really think consumerism and transparency, hospitals are increasingly feeling moved to put their quality data and their cost data online for everyone to see. And you're going to see that very soon for hospitals that quality and cost data up online very soon. And I think once that cost data is up there, I think that's what's going to drive some of the price containment in healthcare. We pay, device companies charge healthcare 7 times as much for the exact same technology used in the hospital than the technology used in the home market. So home technology, 7 times as much for the exact same technology. It's crazy.
I can address a lot of consumer decision making when it comes to health insurance, and that is a function of 3 variables: ability to pay, willingness to pay, and risk aversion. Okay? So insurance is made up of two different decision factors. One is the premium. How much does it cost you to actually have the health insurance? And that's number one in people's minds, because usually when they're shopping, unless, again, you're in a provider environment, you're not sick at that time. So you're just looking at how much is this going to cost me to have this. But then there's the cost-sharing part of it. There's the other side of it. So what if I get sick, how much does it cost me? And one of the biggest complaints about some of the exchange plans was the deductible. I have to pay this much before the insurance kicks in. An interesting fact about Missouri is you had a really interesting situation in Missouri. The McKinsey folks, it's a nonprofit think tank, they said that at the beginning of the open enrollment period that 6 in 10 or 3 in 5 people who were eligible to buy plans on the exchange had access to at least one, what they call a bronze plan, where after subsidies, the premium would be zero. Okay? But there's a little bit of a catch there because those bronze plans have super high deductibles. Most of them had deductibles of $6,300 for the year, which is, I think, the maximum allowable last year. So if you get sick, it's catastrophic insurance. So affordability is in the eye of the beholder, is what I would say. But there are many. But you can dissect it into certain factors that people think about, and it's what they're thinking about now and how likely they think they're going to get sick, whether they think they need the coverage in the first place.
Other questions over here, Dr. East.
About access and you're interested in strategies for providing access to these two populations. Through maybe partnerships or expanding what you do now. Two populations are persons with multiple serious chronic medical conditions and disabling conditions. And the second population is serious multiple medical conditions and mental health conditions. Those are two populations that they need routine health care much more than most people, and yet routine clinic-based care does not work. They can't get there, they can't drive, they have an aversion, they forget their, anyway, two populations, small part of the population, probably 30% of our healthcare costs.
Or more. And I will just, one quick answer, and I will say that we are really looking innovatively at how we can get to those, because those are complex patients. It was the scenario today in one of the, it was Dennis and his story about Bob, and he's homeless, and the mental health clientele, and how do you get to these people? And I would say to you that I sat in and listened intently, and we are looking at things such as nurse practitioners in these hotspot zones where essential one-on-one care and management is necessary. We're looking at community health workers, a variety of different. I think the fundamental answer is we have to deliver care differently in this society, and especially for those very complex, vulnerable populations, it's essential.